We all want to make a difference in our work. And what is that difference that we want to make? Well, speaking for myself and the difference that I've been trying to make in the past few years, I've been trying to persuade the professional bodies that represent you all, and that in a sense license us to then get involved with the mental and emotional lives of the people that we try to help, need reminding that we didn't come into this profession, into this line of work in order to benefit ourselves at the expense of the people that we're trying to help. Ergo, when I speak to those professional bodies, I ask them to put aside the question that they always ask me first: what's in it for us? Whenever I've been trying to get people to collaborate on something that they disagree on, I know they disagree on it, that it's going to be difficult to change, that it's going to be difficult to get agreement on, the first question the professional bodies always ask me: well, what's in it for us to make that change? And so I remind them that the people they represent are not asking that question when they're trying to do their work, helping people on the front line of the work. So that's the difference I've been trying to make, and that's what this day is about, trying to create a coherent discipline that is more than just the sum of its parts. And we are faced with a historic opportunity to transform mental health care. But I'm also going to talk also about the risks and responsibilities involved in that. To my surprise, when I pulled people together in 2007 to form the new Savoy partnership, they did listen. Not all of them, but enough of them so that the others didn't want to then get left out. And when you get a kind of a momentum generated, which I hope today is already evidence of, other people will come along with you. We started that journey, and I'm going to describe that journey for you in 2007, about placing psychological therapists at the centre of modern mental health care. And that's a journey that you're going to now be continuing. And I'm going to put forward a particular argument that you can agree with or disagree with about what I see as the way forward. So that argument is as follows. Since 2007, the psychological professions have undergone a radical, albeit divisive, transformation, in the course of which the scaffolding of a new evidence-based discipline has been erected, and the vision of a new universal access service has been created. What this change amounts to for our professions is not yet fully clear, but by placing psychological therapists at the heart of a modern mental health and social care system, it represents the fulfillment of a vision of care in the community that a previous generation of professionals, politicians, public and other stakeholders tried and failed to put in place. The primary task for the psychological professions collectively is to improve mental well-being, which may or may not turn out to be achievable by reducing the burden of mental illness through access to evidence-based talking therapies. But the scope, and this is the important point I'm going to be, that will run through my theme, and the scale, even of that task, stretches well beyond our existing collective capacity, way beyond what, even when you put all of us together, we have the capacity to do. In other words, there is more work that needs doing than all of us at the moment have the capacity to do. So we have to be thinking about an expansive growth agenda for our discipline. Now, crucially, this coincides with a political debate taking place about the proper role of government, the health service, employers, the community, family, and the individual about the nature of future welfare provision. Where are the share of the responsibility of costs and benefits and responsibilities for support, self-help, benefits provided by the state, benefits provided by employers. This debate we're right in the thick of, and it's going to intensify. So whilst the shape and the identity of the singular professional discipline that we are becoming is still in the process of formation, what is clear is that a collaborative response is called for from our collective leadership, so that a coherent professional perspective is brought to that crucial debate. Our voice on behalf of what we do, on behalf of the people we work with, has got to be a very clear voice in that debate. And I'll tell you exactly the reasons why we've got to be in there. At the heart of that perspective then, I'm saying, is not a sort of top-down kind of leadership, is very much the day-to-day work of ordinary therapists in local services, embedded in representing the concerns and the aspirations of their communities and neighbourhoods, that has then got to be reflected back through our leadership and into this very important political debate. Okay, so that's the, in the first part of my argument then, what I'm saying to you is effectively what I was saying to the leaders of your professions who came together to form the new Savoy Partnership and seize this historic opportunity for change. But I'm also reminding you that we've been here before, we've had this moment of transformative opportunity before, and we failed. And in the second part, I'm going to spell out a bit more the scale and the nature of the challenge that I've talked about, that we can only, in my view, meet collectively by harnessing our forces together and becoming more than the sum of our parts. So that's the intellectual argument that I want to persuade you of. This is a point that several people have already made, but I'd just like to underscore it. We've got two delegates arriving at the venue. One of them asks the other, so what is it you do? So just imagine for a moment then that you're the delegate who's been asked this question. And could we see then, could you put up your hands if in answer to that question you would say, I'm a psychological therapist? Gosh, just one, two, couple, yeah. I'm a CBT therapist. Still, it's a very small number. I'm a counsellor. Few more, okay. I'm a clinical psychologist. The majority, okay, yeah, thanks. I'm a psychological well-being practitioner. A reasonable number there as well, okay. So that's interesting, and presumably then I have missed out quite a few other people as well who would call themselves something different. So the other delegate then asks, so what's that exactly? And what do you say? How do you articulate to a member of the public? And Sue was really saying, I think, to commissioners and to other influential people who actually have got to know what it is you do. How do you articulate that? At the moment, we don't do that very well, and partly because of all these differentiations, which do have a place, obviously, but they get in the way of us being able to really function effectively together. Now, we had a stab at starting this kind of conversation, getting somewhere with it in a project called New Ways of Working for Psychological Therapists. Barry was involved in that, several other people around here were involved in that as well. And somebody's already mentioned that we produced a definition through the Centre for Workforce Intelligence that Neil was involved with of a psychological therapist that can then start to be coded in NHS staff terms. But it all feels like pulling teeth. It's very hard work, it's very slow progress. Why? If there were willingness, it isn't actually that difficult to envisage how we can function effectively as a singular profession. And that's partly thanks to the scaffolding of this distinctive evidence-based way of working that we've been erecting in the past few years. This maps on, as I think you'll recognise, pretty straightforwardly to the domains that you're talking about in this psychological professions network. So we've got a path, we've started to build a path where we've been developing new training curriculums, we've been designing new service models, understanding what works in real world settings. I've been leading the national audit, for example, and then disseminating what I call evidence-based practice, and that is simply practice based on evidence that is meant to enable us to do our best for Musharraf and other people. So we've got the pieces, I think, there. We just need to try to make sure that we can fit them in for this next stage of the journey. And if we can, again, to refer back to what Jed was saying, there's a budget of £700 million in the Northwest, which I heard him say he wants to redistribute. Well, we know where the vast bulk of that £700 currently is being spent. He showed us on the pie chart. But one of the follow-up questions I'm going to be asking Jed then is, and Neil, is let's see how much is being spent then currently on psychological professions and trainings. A lot of you won't have had any funded training to get to where you've got to. There's no reason for that. So we need to set as a goal of this network, seeing how that redistribution starts to get spread towards the network as a whole, but also distributed fairly across this network. So, I think we've got the makings of a singular profession, and it certainly is the case that we have risen now to an unprecedented position of priority in the eyes of policymakers. Psychological professions have never been so central to policy making as they are now. Cinderella, welcome to the ball. The old story of being the Cinderella doesn't wash anymore. We are very firmly now at the ball, and all you have got to do is to learn how to dance without stepping on each other's toes, and then everything will be fine. We'll be able to take advantage of the position that we've got to. But I said earlier that there was a moment when we had the chance of transformative change and we failed it. And it was care in the community. And it comes as a surprise to people that it was a Conservative Health Secretary, Enoch Powell, who launched that, built from the pillars of our modern welfare state, the core function of which, as Beveridge saw it, was to enable civil society to work together to defeat these 5 evil giants: want, squalor, idleness, ignorance, and disease. At that moment in time, what came together then were a series of policy drivers that enabled care in the community to happen. And the first big moment really was when Enoch Powell went to visit the asylums and saw for himself what was actually happening in them. Now, whatever else you think of him, he was a politician who was acutely aware of the tides of change, and he did have the foresight to recognise a shift against locking mentally ill people away. And this was a shift that happened in this country, but also then in other countries around this time. Something shifted to move the consensus away against incarceration. And he was also astute enough to see that the welfare state that had a progressive potential in terms of social housing, access to primary care at the point of need, and that would create a platform on which he could then potentially erect a new model for mental health. And he, I can't do the voice of Enoch Powell, so I'm not going to try, but he set out the vision in a very important speech in 1961 to the National Association for Mental Health, what is now MIND. Now, of course, you know that his expert advisors at that time would have been telling him also of the promising new drugs. In 1952, 1950s, lithium, drugs for schizophrenia, Valium, for anxiety, antidepressants were discovered, furnishing psychiatry with a whole new cornucopia to enable better management of those disorders, with then the idea being that that's possible to do in the community rather than in institutions. So community psychiatry's moment at the centre of Powell's new plan had then arrived. But he wasn't naive either. And his new policy for community mental health was not going to be entrusted just to a single professional group, but to psychiatry and social work, as you can see from this quote, in collaboration. And in fact, a new and quite high status role of psychiatric social worker was then developed, and their moment in social work at the centre of this brave new policy vision had also arrived. So I'm calling this moment the Great Escape, for obvious reasons, and with reference to the film, which I'll come back to later as well. And clearly the test of whether that radical new policy succeeded should first and foremost be whether less people were subject and are still subject to compulsory treatment in acute hospital settings. And as you can see, the picture has changed dramatically. But slightly less obviously, the true test is what then happens to people treated in the community. And that, look at the numbers, 22 million contacts is what our profession is. It is a community-based profession now. So we have to make that count. We have to somehow make those 22 million contacts count as evidence for something that we're doing. But this is one of the central points in my argument. It matters then what happens to the profession when it's trying to undergo fundamental change to what it does and the way it does it. And the view of historians is that the psychiatric and the social work professions at that period underwent a shift towards a more reactive way of working, a risk response mode of working, and actually they did fail to develop then proactive models of care. And events then intervened. In 1992, Jonathan Zito, standing on an underground platform station when Christopher Clunas suddenly, without warning, pushed him to his death under a train. That became a touchstone for a shift in the political consensus. So previously, a consensus against incarceration, and a shift then in the 1990s towards politicians being very concerned about dangers to the public from mentally ill people, and not just the costs of the disease burden, but also the harms involved from mentally ill people to the general public as being one of the key policy priorities. And Great Escape 1 failed as a result then of a standoff, effectively, between the profession that felt it was being attacked and blamed for the situation, and the policymakers that were under pressure from the media to address the situation. Now, I'm not wanting to reduce a very complex set of historical events to a single cause, but I just want to draw attention here to the point at which, in the process of a fundamental transformation, collaboration between different professional disciplines breaks down. because unless we understand our past mistakes, we will repeat them. And if you look at the verdict of failure itself from government, from Frank Dobson, then Health Secretary, what that indicates is that when a professional discipline, when its collaboration breaks down, but also its trust with the public breaks down, it's only a matter of time before it then loses the confidence of politicians and policymakers. And then political consensus itself breaks down about compulsory treatment. And we then enter a period of what effectively could be called adversarial non-collaboration, with a massive fight with Professor Lewis Appleby at the sharp end of that fight for several years. And again, I'm not arguing that no progress was made under Lewis Appleby's regime. That's clearly very much not the case. However, radical reform, transformative reform of a whole profession, of a whole discipline, of the kind that I'm arguing is required if we're really going to meet the unmet needs, was not possible, was simply not possible. The Department of Health, Lewis Appleby, spent the whole of their energy fighting the Mental Health Alliance, led by psychiatry, over the issue of the Mental Health Act in 2007, and compulsory treatment again, that coming around again as an issue. So, just to recap then, what I said is that we do have unprecedented political support that we are enjoying for evidence-based talking therapies, and that Cinderella has definitely arrived at the ball. But I've also pointed to the fact that we must not forget our two ugly sisters, by which I don't mean psychiatry and social work. I mean our propensity to squabble amongst ourselves, as if the only thing is that we've got to do is to win favour of politicians or commissioners for our own benefit, as opposed to being able to collaborate together to meet the inevitable challenge and stresses and strains that a profession will come under when it is trying to do something seriously transformative. So, Great Escape 2, IACT, which I view as the second revolution, where actually it's talking therapies that are the first line, and should be the first line treatment for every mental health condition and beyond mental health also. It's old news now that I described it as life begins at 60 for the NHS when we launched IAPT in 2008, and Alan Johnson and Ivan Lewis managed to win £300 million under the previous government. And then, as you know, we succeeded with lobbying through the new Savoy partnership, the We Need to Talk coalition, to make sure that that commitment fed over into each of the three-party manifestos, which meant, when it turned out there was a coalition government, it was the one thing they had to do in mental health, because both parties had agreed it in their manifestos. But the key revolutionary bit of it, as you know, really pioneered by Lord Layard, was an explicit promise to help people on benefits. So a shift, as it were, in the policy underpinning for what it is we're actually supposed to be doing. To illustrate that briefly then. You've got a bi-directional causal interaction going on, therefore, in this idea that mental distress results from things like being on benefits for years, being out of work for years. And mental distress causes you to be on benefits and stay on benefits for years if the mental distress itself is not then addressed in any way. And the same for the other pillars of the welfare state as well. So this was really something that in the new Savoy partnership we tried to pioneer, building on Lord Layard's work, the idea that actually this was, as it were, a sixth giant that was missing from Beveridge's model. That if you don't address what it is that's going on mentally, psychologically, emotionally for people when they get stuck on dependency of one kind or another, they never get out of it. And that does place us very much centre stage. But here's the problem. And this is inescapable. Low parents, people on incapacity benefits, people on unemployment benefits. The promise that we made with Lord Loud was that we would be helping this middle group, this huge chunk in the middle, get off incapacity benefits and back into work, because that was the thing that that convinced the Treasury to give us the money, that they would see this cost neutral, the services would pay for themselves. So after the economic crash, this is even more a central driver for policy than when we presented this as part of the economic case back in 2007. But look at the scale of the problem. This slide and the next few slides I'm going to show you are based on a report that's just been published by the OECD. So the OECD is a group of, I think, 30-odd member countries across the world, mostly the developed world, but they've got Mexico, they've got the States, they've got most of the European countries, they've got Australia, New Zealand in the OECD. And one of the things that it enables us to do is to make comparative judgments on how countries compare against each other in various areas of economic performance. And they've been looking at this and done a very interesting series of reports around the link between mental health and welfare benefits in different countries. So you can see that the UK is not in a good position comparatively. Not only are we not winning the economic battle, the highest costs from welfare dependency of any country in the European group where we've got the data, but we're also losing the war, it turns out, in terms of a worsening picture of mental health amongst this population group, who are at very high risk of poverty, where a very stark finding, the OECD report, the risk of poverty for people with mental illness in the UK, the highest anywhere in the developed world. There you see in terms of the costs of mental illness as a percentage of GDP, the UK right up at the top there. And the costs in terms of the lives, in human terms, of the lives of those people on whom benefits cuts are falling, as well as the costs of mental illness itself, shows something that we know as clinicians to be the case, but when you see it then set out epidemiologically, the prevalence of mental illness in these various claimant groups, which are the black columns, is significantly higher than the prevalence of mental illness which exists across the population as a whole, which is in the yellow columns. And it's an urgent problem. This is new disability claims per 1,000 population that are coming inflowing to add to the problem every year. And the UK has got the highest number of new disability claims anywhere in the OECD. And the single biggest cause of that, 40% of that is due to mental illness. And now look at the solution. The work programme, which was reviewed by the OECD, and this admittedly is only based on its first year performance figures, isn't working. And in particular, that for people with mental illness, less than 3% of them achieve a return to work. That compares with IAP's figures of 4.3% employment outcomes for this group of people. So neither of these programs, which are the two policy solutions currently being pushed, are actually making any real impact on the issue itself. And hence, if you look across the NHS outcomes frameworks, including the outcomes frameworks for clinical commissioning groups, which they will be held to account for, employment outcomes are in all of them. And the group of people that we need to be helping are very highly represented in terms of needs, unmet needs. So this whole issue of the link between welfare and mental illness really became the kind of central issue for the new Savoy partnership. It started off in 2007 with the push just to get psychological therapies, as it were, on the map of policy making. The issue then is to make sure that the Department for Work and Pensions, which has responsibility for welfare, can actually work and join up in some way with the Department of Health. And you won't believe how difficult that is to get two government departments to actually work together. But at our instigation, the two ministers responsible, Lord Freud, Norman Lamb, actually agreed to meet, and the civil servants had to be there from both sides in a model that I'll talk about later of kind of adversarial collaboration. But their task was to hammer out a joined-up way of doing things in line with the joint pledge that we had got the work programme people to sign up to, as well as the mental health charities to sign up to. And they commissioned then a consultancy called RAND, who also just published a report that sets out 4 cost-effective options for different ways of designing services. And I'm going to come back also briefly to say what that looks like. But the take-home message from this part of my argument is that, yes, policymakers need to design better joined-up policies that can target particularly people who are falling into those 2 small circles there, to do with mental health needs, and especially the ones into the red circle down there. But if you look then at the front line of where sort of welfare reform and support for these people is meant to be happening, which is the yellow line that I've drawn there, notice who the professions are that policymakers are currently depending on to be able to make a difference. They are people in ATOS doing work capability assessments. They are work programme employment advisors interviewing people who are coming onto the work programme on employment support allowance, job support allowance, and who are then responsible for starting to issue sanctions in their benefits, as well as provide the support that is agreed is needed to get these people back to work. Neither of those groups has any training in mental health. We've designed a mental health toolkit that was published by the DWP that the work programme people are all now meant to be trained in, that enables them at least, in theory, we haven't tested whether it's working, but in theory, to begin to identify, to screen, to identify mental health problems in their groups, and then to have some idea of how they start to differentiate and know where would be the appropriate place to get support for those people. That's, as I say, the toolkit and what the toolkit does in theory, and the trainers that we've trained up to deliver it all are enthusiastic about it, but it hasn't been evaluated at all as to whether it's actually making a difference to the way they then work with those client groups. But just at the end of this section then, and I'm conscious that I'm probably going to go over about 5 minutes or something of my time allocation. This is an urgent issue. Post the crash, the government policy, whichever government is going to bear down relentlessly on welfare costs. That's a fact. There's nothing we can do about that. However, well-being is at the centre then of the desired outcomes from a number of different angles of policy. Policy around growth, policy around welfare reform, plus a range of public services that are increasingly being delivered within payment by results frameworks. All those are going to take further shape post the election to try to deliver something called well-being. There's only one problem with that, which is that well-being can't be judged, in my view, by an average, and it's context dependent. But all the more reason then why this network needs to be getting involved in those policy discussions to define what, in those specific contexts, well-being needs to mean, something that is meaningful in terms of the transformation that we have a good sense of in terms of the clinical work that we do. So, what I think I've shown in the context of mental health services is that we are going to have to invest more in targeted efforts to reach these populations who are dependent on welfare benefits if we're going to make a difference, and that welfare reform actually is the crucible wherein what happens to people with mental illness will be decided. So whether they sink further down or can turn their lives around through work will be decided in terms of what happens around welfare reform. And what I want not to happen 2 decades on in 2018, as it were, is for Great Escape 2 to then have been judged a failure likewise. Talking therapies are now widely seen as central to unlocking someone's inner resources to get off welfare dependency. But our Great Escape is no more guaranteed than the Great Escape that came before us. And this is the challenge. I had the courage to step up initially to that challenge. But what's happening to those people who are getting left behind? It's fantastic that IAPT by 2015 is expecting to have helped 400,000 people to have recovered. But what about the 1.6 million people in the 2 million people that have gone through, who will still be left behind? And so, whether it's Jeremy Hunt or Andy Burnham or some strange inbred mixture of the two of them, the facts are not on their own friendly. They're not likely to change of their own volition. We've made a very strong case about the value of talking therapies, and we've seen that people with mental health needs are very overrepresented in the welfare population. So the scale of the task that I want to impress on you remains vast. We've really got to be thinking very ambitiously, very expansively to address the task ahead. Okay, so final few slides with a question. Is reducing the burden of disease, mental illnesses enough of an ambition? Do we even have a shared model of what that would involve? Or could we come together in a more creative way to go beyond that and to think somewhere else? I'm not offering the new Savoy partnership and what happened with that as an exemplar for you to follow. However, we were able to agree a series of common positions around important things, and none of those things that we started discussing looked at first sight as though we would actually get to any agreement. But if we're going to become a force to be reckoned with, in Sue's words, we're going to have to continue that process of getting into debates about things we don't necessarily agree on and finding a way to reach a common position. The reason being, or the main mechanism to do that is to keep focused on this bigger picture. Look again at where the UK is on the provision of psychological therapies, which is that little, in the case of the UK, that tiny little sliver in the middle, compared to what is being spent on antidepressants and then on a combination. And that doesn't compare well with European averages or with some of the other countries in Europe. That's the task. You've got to change that picture. And if you don't, then this is what happens. Spending on talking therapies is a tiny proportion of total mental health spend. Talking therapy services are chronically underinvested in, continue to be chronically underinvested in, and as a result, a waiting time of 4 weeks is not achievable by services. And the Northwest, you can see in the light blue there, has quite a challenge of its own in terms of meeting waiting times targets for access to talking therapies. The fact is, in the New Savoy Partnership, all the central issues that we needed to find agreement on, we actually uncovered deep-seated disagreement over. And this is my other warning to you, is that of course you've got to have disagreement. You're not going to get different professional groups agreeing on things. But if the whole of your energy is taken up in that disagreement and in our case successfully resolving the disagreement, nevertheless the face of the map itself then does not get changed. It's not cost neutral. Psychological therapy services are down there at around about 7% of the total mental health spend. That mental health spend itself needs redistributing on service provision in exactly the same way that Jed was talking about for education and training. So avoid epistemic hell. Adversarial collaboration I would like to commend to you, which is something Daniel Kahneman has written about, and also these guys called Tetlock and Gregory. In an interesting article, Implicit Bias and Accountability Systems, what must organisations do to prevent discrimination. And what they say about epistemic hell is that if you can't agree at the outset on what kind of evidence from your side would be able to convince the people you disagree with in the argument on the other side that actually you were right or you were wrong, you remain in epistemic hell. You've got to get some agreement on what could convince you to be able to change your mind and allow you to move forward with these arguments, so that you can agree to continue to disagree, but nevertheless recognise that there are certain points that have been shown in the argument that you need to accept. And if you can do that, then what I'm saying is you should be aiming to see yourselves more as a social well-being profession. That the areas of need that I've been talking about with this vast area of unmet need amongst welfare claimants are largely sustained by social causes, social factors in people's lives that you've got to, in collaboration with other professional groups, find a way to be able to make an impact on. Final thought. The film The Great Escape, most of you will have seen it, did not actually end very happily. And I haven't been a sort of, I recognise I haven't been a sort of fountain of joy and happiness in the picture that I've been presenting to you of the kind of challenge that faces you. So 250 prisoners of war, you remember, dug the tunnels, escaped, but by the end of the film, all but 3 of them have been recaptured and the leader executed, along with 50 others of them on direct orders from Hitler, executed. But that's not the point. What I'm saying is that what the prisoners discovered in their efforts to escape is something that's much more profound about the human spirit and our capacity to work together and our capacity to do something for the common, not only the common good, but also for people like Musharraf, which goes way beyond the pursuit of individual happiness. Thank you.